Welcome to the Human Momentum Podcast. My name is Erik Schabert, and I'm a doctor of osteopathic medicine with more than a decade of experience in primary care and manual medicine. My goal with this channel is to make it a resource for anyone who is interested in learning more about the latest that medical research is telling us. I made this channel for everyone who is looking to learn a little bit more about health, medicine, and nutrition, and is a bit confused about all the contradictory information that's out there on social media and in the mainstream media. If that's you, listen up, because I've got a great episode for you today. If this is your first time here, please hit that subscribe button. And if you find this information interesting or helpful, please do give this video a like and share it with somebody in your life that you think could benefit from it. And finally, if you have additional questions or a topic you'd like me to cover, let me know in the comments section. I read all of my comments and respond to many of them. With all that said, let's get on with today's episode. Welcome to this second July episode of the Human Momentum Podcast. Today's episode is going to be all about responding to a message an elderly friend of mine forwarded me on Facebook. This message is from one Dr. Joseph Mercola, and you can see that message on your screen now. In this message, he makes a statement saying that although statin medications do lower cholesterol, they don't do anything to address the underlying inflammation that he feels causes the majority of cardiovascular disease. And he says that reducing linoleic acid consumption to 5 grams a day will reduce C-reactive protein, which is implying that this does address the underlying inflammation and will better cut cardiovascular risk than a statin will. It's a bold claim. And I would argue, in light of our current available medical research, it's a deeply flawed claim that is, in fact, entirely incorrect. I'm going to go over that claim and a few others that Dr. Mercola makes in the linked information that you can see in that message. And I'm going to use current medical research to show you exactly where I believe he went wrong and what we can do instead to get better outcomes than his approach would achieve. As we get into this, I really want to hear your own opinions on the current medical therapies for prevention of heart disease, including statin medications, where you're at on supplements for this purpose. How are you approaching trying to minimize your own cardiovascular risk? Go ahead, let me know in the comments. I'm going to read them all, and I'm going to try and respond to them as best I can and give you where I think we're at based on the current information. A lot of that is going to be in the rest of this video too. So if you're interested in a former primary care doctor's opinion on this, watch through to the end of this video and you're going to see much of what I think on this topic. As we begin this discussion, I want to go in a little bit about exactly who Dr. Joseph Mercola is and compare his training and credentials to mine to add some context. There are quite a few similarities when you look at his training background and mine. He graduated from Chicago College of Osteopathic Medicine in 1982 and completed an AOA certified family medicine residency in 1985. By comparison, I graduated from what was then the University of Health Sciences College of Osteopathic Medicine in 2004, and I attended the integrated family and neuromusculoskeletal medicine residency at what was then Florida Hospital East Orlando, now Advent Health East, in 2008. Dr. Mercola started a website in 1997 focused on health and wellness and left practice and became a full-time author and online influencer in the health and wellness sphere in 2007. He does hold a fellowship in the American College of Nutrition. I'm not really familiar with exactly what the rigors of obtaining that credential are, but it is significant to this discussion. He has generally been a prominent author and spokesperson for lifestyle and wellness medicine since 2007, with a good deal of controversy surrounding him as well. But today, I'm going to just focus in on his claims regarding statin therapy and the seed oil-related fatty acid, linoleic acid, and we'll break that down, and I'll let you know what I think. I want to begin with the claims that are on some of the material that this original post that was forwarded to me links to on Dr. Mercola's webpage. Here is a summary of the claims he's making. First thing I want to address is this claim he is making that the underlying cause of heart disease can be better addressed by restricting linoleic acid to 5 grams daily instead of using medications like statins. To do that, I want to break down exactly what linoleic acid is, why we actually do need some of it, and why I believe that his take on linoleic acid might not be what we're actually looking for if we're trying to pursue optimal health. Linoleic acid is actually an essential fatty acid. What this means is that it's a fatty acid our body can't make, and we have to get however much we need from our diet. This is where I begin to have a problem with Dr. Mercola's recommendations. He is advocating cutting linoleic acid intake to 5 grams daily. I have no idea where he's getting that number from, or the idea that it could cut C-reactive protein by 15%, as I could find no published research on PubMed that pointed to this kind of benefit or that restricting linoleic acid intake was a good idea. And to be clear, the recommended daily intake for optimal health in the United States is 12 grams daily for women and 17 grams for men. These are supposed to be the minimums in order to be healthy. To be fair, Dr. Mercola also states elsewhere in the publication that his original post I was forwarded linked to, that avoiding foods containing linoleic acid is very difficult because it's added to so much processed food, so that trying to cut to 5 grams is fine because you'll get enough for your health processes just accidentally. Isn't this a bit contradictory, though? The idea that you should shoot for a 5 gram daily intake, but it's impossible to get there? Yeah, it doesn't make sense to me. That said, I also don't see any evidence that restricting linoleic acid daily intake is going to have a significant positive effect on heart disease risk. As a matter of fact, our available epidemiologic research points in the opposite direction, indicating that when you replace saturated fats in the diet with polyunsaturated fats like linoleic acid, you actually get a significant cut in all-cause and cardiovascular mortality. While I couldn't find any specific medical research that Dr. Mercola would be citing to come up with the idea of limiting linoleic acid like that, I did see some things in the rest of the material he had on his initial website and in a few of his other videos I listened to that does point to where he's getting this idea from. In a bunch of this material, he goes into an idea that in 1900, we had much lower reported heart attack and stroke incidence in the United States than we do today. And back then, we were cooking with butter and lard primarily, and we were eating more red meat. And generally, we consume less food that contained seed-related oils like linoleic acid. He points to the fact that in 1920, a company introduced the product Crisco, which was made from cottonseed, a vegetable oil, and that decades after that, we began to see a precipitous increase in heart attack and stroke incidence in the US, particularly after World War II. Now, it's true that Crisco is something that's rather problematic, but not only is it a vegetable oil, it also originally contained a lot of trans fat. And trans fat is something we have long known is a big cardiovascular risk factor. It's even worse than saturated fat. Now, another thing that he isn't taking into account, particularly when we start comparing heart disease rates in, say, 1970 to heart disease rates in 1900. In the early 1900s, life expectancy in the US was between the late 30s to early 40s, depending on whether you're talking about men or women. A lot of people were dying in childhood, adolescence, and early adulthood from things like vaccine preventable illnesses and bacterial infections that can be cured with antibiotics. The introduction of those, along with much better public sanitation, led to a big jump in life expectancy and far more people just living long enough to get heart disease. He also points to something called the Seven Nations study that was done in that post-World War II period to try and tease out exactly why we were seeing this big jump in cardiovascular disease incidence. This is a study that was headed by a researcher named Ansel Keys. And when it was published, they came back with the conclusion that it was saturated fat in the diet that was driving heart disease risk. And the food industry response to this in the 1970s was to introduce a lot more vegetable oil-based alternatives to saturated fats in order to push people away from that in the idea that it would reduce heart disease risk. But truthfully, this was the food industry's response to the vilifying of things like butter and seeing an opportunity to make more money by introducing these new products. And over time, this has led to a significant increase in linoleic acid consumption in the United States. And yes, that is tracked with an increased incidence in heart disease. Dr. Mercola's recounting of the fact that we used to eat a lot more saturated fat in 1900 and that the rate of saturated fats were restricted in response to the Seven Nations study, that is entirely accurate. The problem I have with it is the analysis that this increase in seed oil intake is what is driving chronic disease, especially cardiovascular disease in the United States. I think that's severely flawed. As I alluded to before, I think it's got a lot more to do with the fact that we introduced measures like vaccines that reduced childhood mortality greatly. We introduced antibiotics that reduced mortality in childhood, adolescence, and adulthood vastly. And the fact that people were no longer dying of infectious disease anywhere near as often meant that when they weren't previously, they're now living long enough to develop cardiovascular disease, have heart attacks and strokes, and die from that instead. So this idea that just simply looking at the increase in linoleic acid content between 1900 and today and relating that increase directly to the increase in cardiovascular disease, I think that is a severely flawed viewpoint, really misses what's actually going on here. Now, the one caveat to that I will introduce is that we have seen a big jump in obesity, and seed oils do deserve some of the blame for that, but only insofar as they tend to be ingredients in highly processed foods. And I think it's the move from whole foods to highly processed foods that has driven this obesity jump, much more so than it is seed oils alone. Certainly, consumption of refined carbohydrates along with seed oils can be implicated. And those are two of the primary ingredients in a lot of highly processed foods that I think are really problematic. And one of the things to note is that seed oils are not anywhere near the only thing that is overconsumed in the US right now, leading to this obesity epidemic. As I alluded to, refined grains, refined sugars, protein, and saturated fat are all overconsumed in the US right now. And all of these feed into that obesity epidemic. About the only thing Americans don't get too much of are fruits, vegetables, and fiber, all of which would probably help the problem. Next, I want to talk about Dr. Mercola's claim that statins don't address the inflammation that he feels is underlying the increase in heart attack and stroke incidence in the United States, and that they are additionally harmful to take. These are Dr. Mercola's claims about the lack of positive effects of statins and the adverse risks associated with them. I'm going to break down each of these ideas, starting with the adverse events, and show you with research why these risks are being overstated and the benefits of these medications severely understated. We can begin this side effect discussion with statins and muscle pain. Statins do have a very real potential to generate muscle-related toxicity, but it's much more rare than Dr. Mercola is stating it is. A large meta-analysis of many of the randomized controlled trials utilizing statins showed that true muscle injury only occurred at a rate of 1 in 10,000 patients per year of treatment, and the more serious event of rhabdomyolysis only occurred at a rate of 2 to 3 patients for every 100,000 treated for a year. As a reference point, this is well below the serious adverse event rates for both ibuprofen and aspirin, medicines we frequently take without even thinking about it and really think of as safe. Additionally, analysis of statins versus placebo showed that muscle pain occurred at 90% of the rate for statins in the placebo group during these randomized controlled trials where they were approved. Researchers have termed this the nocebo effect, basically a placebo with a negative effect. Now, again, there are real muscle pain issues and muscle-related issues associated with statin therapy, and I'll talk a little bit more at the end how we prevent this kind of thing. We next need to discuss statins' effect on blood sugar. There is a real negative effect here, and it's significant. It's the side effect we need to track most aggressively and work to prevent. A 2010 meta-analysis of statin-related trials published in The Lancet showed a 9% increase in diabetes attributable to statin therapy. This can be monitored using a test called a hemoglobin A1C prior to initiation of your initial statin and rechecking it periodically to ensure that insulin resistance and blood sugars aren't increasing. Additionally, exercise and modification of diet can prevent this effect, as can minimizing the dose of the statin therapy and potentially switching to a statin that is better tolerated than one that is beginning to cause this problem. A similar approach can be used with liver injury, which does happen on statins. In my experience, I only saw it when statins were being used and another drug was initiated that had an interaction with the statin, or if a patient was on a drug that had a potential drug interaction with the statin and the physician initiating the statin didn't know it. Along with that, though, keeping the dose low can prevent liver injury. Dr. Mercola admits in his own information that you can see here that statins reduce major adverse cardiovascular events, also known as MACE. He cites a rosuvastatin study showing a 44% relative reduction in MACE and claims that because this same study supposedly also showed a mild elevation in C-reactive protein, we should believe the statin isn't really that effective at preventing cardiovascular disease. This whole idea demonstrates a fundamental misunderstanding of what MACE actually is. Major adverse cardiovascular events absolutely includes things like heart attacks, strokes, symptomatic peripheral arterial disease, and heart failure, all of which he's saying could go up because C-reactive protein elevated. And yet the study shows a 44% reduction in all of these things. And that would also include, incidentally, the risk of aortic dissection related to atherosclerotic vascular disease, also known as ASCVD. And that is what killed Lindsey Graham recently. Just sort of an interesting aside. I also want to mention that I could not find this particular rosuvastatin study, and the overwhelming majority of research out there on statins shows a consistent reduction in high sensitivity C-reactive protein when you initiate statin therapy. I want to go a little bit deeper and dive into what research shows about statins' effects on cardiovascular outcomes, because I think it's important to understand this. While statins have shown improvement in MACE risk for what we call high-risk patients, they have failed in the general population to this point. And I want to talk a little bit about why I think that is and what that means. First off, a high-risk patient is what we call a secondary prevention patient, meaning they already had a primary event, a heart attack, stroke, new onset heart failure, or some other major adverse cardiovascular event. Now, it also can be, though, individuals with known ASCVD detected through other means, such as a carotid ultrasound or a imaging of their coronary arteries showing plaque formation. Any of these things would put someone in the highest risk category and would mean that initiating statin therapy in that population would be expected to reduce major adverse cardiovascular events. I believe a study called the PISA study recently showed us exactly why statins have failed in primary prevention thus far and what we can do differently with cholesterol treatment to start to get reliable primary prevention of major adverse cardiovascular event risks. The graphic you see here shows very clearly that when we get down below 55 milligrams per deciliter in LDL, you will see that the progression and potential instability of soft vascular plaques goes away. And as a matter of fact, below 55 milligrams per deciliter, we can even see the reversal of plaque deposition in the arteries. And so the implication of this data is that we can minimize MACE risk in primary cases, people who aren't at elevated risk, by treating to this lower number, and that we can get even better secondary prevention by treating down to 55 milligrams per deciliter. Just to be aware, the previous recommendation was to treat to 70 in high-risk patients and below 100 in lower-risk patients. I think ongoing studies that are underway now are going to show that treating to this lower 55 milligram per deciliter target is going to show primary prevention benefit in this moderate to low risk population that we did not see previously. There is a study out of South Korea that compared treating to 55 versus treating to 70 in higher risk patients, and they actually had to terminate it early because they were showing so much benefit of treating to the lower number. The exciting thing is that South Korean study showed that 55 milligram per deciliter target can most frequently be hit by using a cheap generic statin at a low to moderate dose and combining it with the inexpensive medication ezetimibe. Using the two of those together and leveraging diet and activity to the maximum will let the majority of individuals get to that 55 target without having to spend a lot of money. I think that's very exciting. Another thing I want to point out is that this reinforces the work of another healthcare maverick, an MD and former cardiovascular surgeon by the name of Caldwell Esselstyn. He now dedicates his practice to lifestyle medicine. He's advocated a very low-fat, plant-based diet for a long period of time and had accumulated data in a handful of his patients where he followed them long-term with serial cardiac catheterizations and showed reversal of coronary artery plaques. A lot of physicians were very skeptical of these results, but seeing this replicated now with a different method of hitting those very low cholesterol targets makes me think that Dr. Esselstyn was onto something, at least for the idea of hitting those low targets, even though I found his entirely plant-based, extremely low-fat diet very difficult for me personally to follow. Next, I want to look at exactly what is possible when we take absolutely everything that epidemiology has taught us about lowering cholesterol with diet and just how effective that can be. In this graphic here, you can see the kind of dietary interventions that were used in this study. What they had here was a diet that tried to incorporate a lot of foods we know lower cholesterol, and they wanted to compare it to a low saturated fat Mediterranean style diet and that Mediterranean style diet plus a statin. You can see here the results of this study were rather impressive. This index diet, as they called it, reduced cholesterol by almost 29%, whereas the statin plus Mediterranean diet got just above 30%. So there were similar results there with diet alone. Now, something we do have to put in as a caveat here is in this study, these individuals lived in the nutrition lab and they were fed all of these meals. They were all prepped for them. So there was no real world element. And when they went back to the real world, the efficacy of this index diet dropped down to about half of what they saw in the lab, around 14% reduction in LDL instead of 29% reduction, just due to the fact that in the real world, it's very difficult to prep all of your own meals and do it perfect. And that's why, tying everything together, I really believe the best approach to minimizing major adverse cardiovascular event risk is wrapping in diet, activity, and medication interventions. The truth is that most of us aren't good enough through the majority of our lives about really prepping ideal meals with adequate fiber intake, relatively low intake of saturated fat, and low intake of processed meats and other highly processed foods so that we can get towards the latter part of life without having some degree of ASCVD. And once that's present, you almost have to use medications to hit the kind of cholesterol targets that will begin to reverse it, or you have to go to a very extreme diet, something like Dr. Esselstyn's diet. I don't think the kind of dietary interventions that Dr. Mercola is prescribing are likely to reduce risk at all. So I'm really concerned about him putting out this idea that statin therapy is bad, other medical therapies may be bad, and that you just need to cut linoleic acid low enough and you'll be fine. Because I don't think that's true. There are a lot of influencers out there who talk about the idea that your LDL cholesterol levels, your ApoB levels don't really matter if you're metabolically healthy. I also think this is most likely not true for the majority of individuals. There may be exceptions to that, but for the majority, you're cruising for a lot of risk if you go down that path with your health and lifestyle choices. At that point, I want to just say thanks for tuning in. And if you found this information helpful, please like the video and hype it if you're watching on mobile. Please also share the video with someone you think could benefit from it if you found it informative and think it's worth putting out to other people out there to get good information. Also, don't forget to subscribe if you haven't done so already. It really does help me with the algorithm. I look forward to seeing all of the comments you guys are making about how you approach cardiovascular health and what you think is true. Thanks again for tuning in, and I'll see you next time.